All right, welcome back. Last time we talked about blood, and so now we're going to talk about the organ that pumps that blood, which of course is the heart. But before we get into the anatomy of the heart, I have an historical aside for you. And so the question I have for you is why is the marathon, which is a race of 26.2 miles, called a marathon? And so the reason that it's called a marathon, oftentimes, obviously this is part of a class discussion, kind of a prompt. Um, and so usually the guesses that people throw out there, eventually somebody gets pretty close. And what people have heard is usually that there was some sort of an ancient athlete, possibly a Greek athlete, who ran that distance and then died at the end of the run, which is pretty close. Um, the legend is based on an individual from Greece in the 5th century BC. His name is Phidippides. And so basically, what happened, or how the legend goes, is that Phidippides ran from Marathon to Athens and died as a result of the run. So let me give you a little more background on that. So in the 5th century, there were the Greeks, the city states that you're familiar with, so Athens, Sparta, Thebes, etc. And across the Mediterranean to their east was the Persian Empire. So the Persian Empire occupied what is present day Iran, Iraq, and into Turkey. And so the Greeks actually had some colonies in western Turkey, kind of on the coast of western Turkey. And so those colonies decided to rebel and to try to overthrow Persian rule. And so the Athenians, the people from Athens, helped them out with that rebellion, which ultimately the Persians put down. And so basically, the Persians got tired of the Athenians causing them problems and decided to invade the Greek mainland. And so in 490 BC, you get the first of the Persian Wars. So the Persians invade Greece. If you've seen 300, I know it's an increasingly dated reference, but if you've seen 300, that's what that movie is based on, is one of the Persian Wars. So at any rate, the Persians go to invade Greece, and most specifically, they're interested in attacking Athens. And so the Athenian army meets them on the plain of Marathon. And so, despite being greatly outnumbered, the Athenians are able to repel the Persians. They defeat the Persians and then send them packing, send them back to Turkey where they came from. And so, the legend is that Phidippides was a messenger who ran from the battle at Marathon all the way to Athens to the Athenian Senate. And then he said, "Be happy, we have won," and then fell down dead. The trouble with that story is that it's not true. It actually didn't show up in the literature until several centuries after the event. But nonetheless, that legend captured the imagination of the creators of the modern Olympic Games, which started in 1896. And so there was a race called the Marathon, which is based on this legend in the very first Olympic Games. But the first marathon wasn't even actually 26.2 miles. The reason that the marathon is 26.2 miles comes from the 1908 games, which were held in London, and that's actually the distance from Windsor Castle to London's Olympic Stadium at the time. And moreover, the additional zero point 0.2 miles comes from the part of the track that the athletes had to run around once they got into the Olympic Stadium so that they would finish directly under the royal box. And so that's how we ended up with that distance. Is it was actually a distance in London and had nothing to do with ancient Greece. And in fact, what probably happened, if there was an individual named Phidippides who engaged in any sort of a run related to that Persian invasion, was that he ran from Athens to Sparta, so from one city state to another, to ask for help with the battle, basically to ask the Spartans to get involved to help repel the Persian army. And that feat would have meant that he covered, or according to that iteration of the legend, he would have covered 155 miles over the course of 2 days, which is still pretty impressive. That's an ultra marathon. But nonetheless, if you've heard the legend of the marathon that somebody ran 26.2 miles and shouted, "Be happy we've won," or whatever, and died, probably not true. And again, the distance is essentially arbitrary. It was basically a really long race, and that happened to be a convenient distance for the 1908 games. And so that's where the Olympic distance comes from. So the reason I mention it for the heart chapter, though, is that that is the first purportedly documented evidence of death related to exercise or death related to overexertion. And so In fact, cardiac deaths or exercise, well, yeah, let's stick with that. Cardiac related deaths concurring with exercise or occurring during exercise afflict one out of about every 100,000 athletes per year. So it's relatively rare, but it does happen. And so this story, if you will, was the first type of story where there was sudden death in an athlete. And so that's why I mentioned it with the heart. All right, enough of the history and on to the anatomy. So, in terms of the basic structure of the heart, oftentimes in books it's discussed as being effectively two side-by-side pumps. So there's the right side and there's the left side. And one thing I should point out in terms of right and left in the heart, and I'll pull up my pointer here, is it's the patient's right or the patient's left, or the athlete's right or the athlete's left, however you want to think about that. So the right side of the heart is going to be over here because, again, it's their right side, so it's a mirror image from you. And then the left side is over here, again, a mirror image from you. So the right side of the heart receives deoxygenated blood, or at least blood with a reduced oxygen content, and it pumps that blood to the lungs. So you can see there that there's a pulmonary circuit. Anything pulmonary is the lungs. And so the right side of the heart takes deoxygenated blood and pumps it to the lungs, where that blood offloads its carbon dioxide into the lungs, into the alveolar air, which is the air that we've breathed in, and it's in alveoli. And then we onload, or we pick up, oxygen. So then that becomes oxygenated blood. On this drawing, the deoxygenated blood is signified by being blue. The oxygenated blood is signified as being red. And then we return that oxygenated blood to the left side of the heart, which then ejects the blood out to the body. And that's the systemic circuit. So that is the flow of blood throughout the body. So basically everything other than the blood that flows past the lungs. So the pulmonary circuit is sending deoxygenated blood to the lungs, and then the systemic circuit is everything else. So the right side of the heart takes deoxygenated blood to the lungs, left side of the heart brings freshly oxygenated blood back from the lungs and circulates it around the body. And we'll talk more about the chambers of the heart here in a second. All right, so in terms of the location of the heart, so remember that we talked about back in chapter 1 or 3, I think, when we talked about different cavities. So remember we talked about the dorsal and ventral body cavities. And so the ventral body cavity, that's the one in the front, and that had the thoracic and abdominal cavities. And in the thoracic cavity, we talked about the pleural cavities where the lungs are. And then we talked about the mediastinum, which is in the middle. And so the heart sits in the mediastinum, but more specifically, the heart actually sits in a sac called the pericardium. And so, there we go. So there's a picture of the heart and the pericardium as well. A couple things about the heart. So in terms of the mediastinum and all the stuff that I have on there, base, apex, and apical impulse. So the heart is like the patella in that the base and apex are flipped upside down. So the apex is pointed down. It actually points toward your left hip. And then the base is more superior and actually leans toward your right shoulder. So the heart sits at kind of an angle in the chest. And then the apical impulse is where you can feel where the heart's apex bumps up against the chest wall. And that's palpable between the 5th and 6th ribs, typically just below your left nipple. But again, between your 5th and 6th ribs is where you can find that apical impulse. So you can kind of feel your heartbeat if you kind of poke around between your ribs, sort of lateral and inferior to where pec major is. All right, so that stuff covered. Let's talk about the pericardium. So again, the pericardium is the sac in which the heart sits. And so there's two parts to it. So there's the fibrous pericardium. And so the job of the fibrous pericardium is primarily to protect the heart, but also to anchor it to those surrounding structures. So to anchor it to those pulmonary cavities and the structures that are associated with those. So it keeps the heart in place. So anchors it and then obviously protects it because it's going to be a dense, irregular kind of tissue. And so that's going to help protect the heart. And then in addition to that, or deep to that, more accurately, you've got the serous membranes. So remember the serous membranes we talked about way back with, I think, chapter 1. So remember that there's two layers of serous membrane. So there's a parietal layer and a visceral layer. And so the parietal layer is just on the inside of, and I'll pull up my arrow again, you can see here the parietal layer is just on the inside of, or just deep to, that fibrous pericardium. All right, and then we've got the visceral layer there, so this white tissue here. So that's the visceral layer of the serous membrane. And so remember that those serous membranes secrete a fluid. So essentially you've got the pericardium, which is the sac that the heart sits in. You've got your serous membranes that secrete serous fluid. So the heart kind of floats in a fluid. And that enables it to stretch quite a bit whenever we are engaging in intense exercise. So it floats in that fluid. And again, that serous fluid helps lubricate, helps keep the heart from rubbing up against the pericardium and causing damage to the heart. So in terms of the layers of the heart, so the way this is laid out here, you can see the epicardium, which is the same thing as that visceral layer of the serous membrane, and then you've got the myocardium. So the myocardium is the muscle of the heart, and then deep to that we've got the endocardium. So remember that the endothelium is the inner lining of blood vessels. Well, the endocardium is continuous with the endothelium of the blood vessels that empty into the heart. So the endocardium is essentially just an extension of the endothelium, is one of the ways to think about it. All right, so let's talk about the different chambers. So this, what you're looking at here, so this is obviously just the heart and the primary vessels. And then I'm going to click one more time, and there you get a frontal cut of the heart, so you can see inside of those chambers. So there are 4 chambers to the heart. There are 2 atria. So right and left atrium, atria is plural, and then there are 2 ventricles. So the atria are the smaller chambers on the top. So here's the right atrium that I'm mousing over now. Here's the left atrium over here. And then here is your right ventricle down here, and then left ventricle over here. So the other terminology on this slide deals with the blood flow back to the heart. So all of the blood from the body coming back to the heart empties into the right atrium. And so the structures you can see there, so there's the superior vena cava, and so that's spelled for you here. So you got superior vena cava here. So blood coming back from all of the body that's above the diaphragm, so basically from your upper body, all of that blood empties back into the right atrium via the superior vena cava. Then you've got the inferior vena cava, so everything below the diaphragm comes back to the heart via the inferior vena cava. And then the coronary sinus is going to deliver blood back to the right atrium that has participated in the heart's circulation. So the heart has its own separate circulation, so the coronary circulation. And so once oxygenated blood is filtered through the myocardium, and then it becomes deoxygenated blood, it empties back into the coronary sinus, which then empties back into that right atrium. So between the superior inferior vena cava and then the coronary sinus, all of that blood empties into the right atrium. And then what's going to happen is that the right atrium is going to contract, and it'll push blood down into the right ventricle. So we're going to push blood down into here. Then the right ventricle is going to contract, and that will then eject blood out. Trying to bring my mouse back. There we go. That'll eject blood out into the pulmonary arteries. And so you can see those branch into the left pulmonary artery and the right pulmonary artery. And so those go to the left and right lungs respectively. And then that blood will become oxygenated, and it will empty back into the left atrium. So here's your left atrium. So now that freshly oxygenated blood empties back into the left atrium via the pulmonary veins. So here's your left pulmonary vein, or veins there, and then the right pulmonary veins are over here. So then those are going to dump back into the left atrium. It'll contract, push blood down into the left ventricle, and then it'll contract, and then eject blood out into the aorta. And so the aorta, as we'll talk about later, has a really thick muscular wall. It's very elastic, so it's able to stretch and return back to its original shape, and that then helps propel blood out through the systemic circulation. So, and you can see these major offshoots here that go superiorly toward the head. So then the basic path of blood flow through the heart is deoxygenated blood empties into the right atrium, down into the right ventricle contracts out to the pulmonary arteries, and then becomes oxygenated blood, comes back via the pulmonary veins into the left atrium, down into the left ventricle, and then out into the aorta. one of the fun facts about this, so I mentioned in a previous lecture, so arteries always go away from the heart, veins come back to the heart. In general, arteries carry oxygenated blood and veins carry deoxygenated blood, but here are the exceptions. So you've got the left and right pulmonary arteries. So those two are carrying deoxygenated blood, and then you have the left and right pulmonary veins. Those two are carrying oxygenated blood. So other than those two outliers around the heart, the rest of them, arteries carry oxygenated blood, veins carry deoxygenated blood, but these two are the exceptions to that general rule. All right, so let's talk about valves. So you probably saw the valves or noticed the valves on the last slide. So I'm going to click one more time. There we go. So we're looking at the same view that we did on the last slide. So there's the atrioventricular valves, or AV valves for short. So the atrioventricular valves, as you probably would have guessed based on the name, sit between the atria and the ventricles. So the atrioventricular valves, one of them is here. So I'm mousing over it there. That's one AV valve. And then the other AV valve is over here. So the job of the valves is to prevent the backflow of blood. So you've got special valves in the heart that do that, but then also on the venous side, in the lower body in particular, you have valves that prevent the backflow of blood there as well. So anytime we've got a valve, its job is going to be to prevent the backflow of blood. So for example, we'll stay over here on the right side of the heart. Actually, before I do that, so in terms of the AV valve, you've got the tricuspid valve, tricuspid valve over here, and then the mitral or bicuspid valve over here. So the tricuspid valve then is on the right side of the heart, and one of the ways to remember that is try to be right. So tricuspid valve then is on the right, and then the bicuspid valve is on the left. So tricuspid versus bicuspid deals with the number of flaps there are in the valve. So the tricuspid valve has 3 flaps, the bicuspid valve has 2. And so what ends up happening, sticking on the right side of the heart and with the tricuspid valve, whenever the right ventricle contracts, so effectively what happens, it's going to contract from the apex down here, and that'll push blood up. Now, the blood can either go back into the atrium or out here through the pulmonary arteries. But since that valve is going to snap shut, since the tricuspid valve is going to snap shut there, it prevents the backflow of blood back into the atrium, and so then what we get is just a one-way flow of blood into the pulmonary arteries. And then same thing with that oxygenated blood comes back into the left side. When the left atrium contracts, pushes blood down to the left ventricle. When it contracts, that bicuspid valve is going to snap shut and prevent backflow back into the left atrium. And instead, there's only one way that blood can go, and it has to go out here through the aorta. So there's a couple other terms on there. So the chordae tendineae and the papillary muscles. So the chordae tendineae are these little connective tissue strands right here. They're connected to the papillary muscles, and so what both of those structures do is they help keep those valves closed, and they help keep those flaps nice and tight against each other, because as you can imagine, there's a tremendous amount of pressure, especially during really big heavy lifts or really strong sustained contractions. That's a lot of pressure that's going to be exerted against those valves, and so between the chordae tendineae and the papillary muscles, that helps hold those valves closed and also nice and tight and flushed against each other in terms of those flaps. The other set of valves, other than the atrioventricular valves, are our semilunar valves. So the semilunar valves sit between either ventricle. So in this case, between the right ventricle and the pulmonary artery, you have the pulmonary semilunar valve. And then over here, this thing that you can't really see very well, but it's right here, that's your aortic semilunar valve. And so what the semilunar valves do, same thing, they prevent backflow of blood, in that case, back into each of the ventricles. So when the left ventricle contracts and pushes blood out into the aorta, as mentioned, the aorta is going to be able to stretch and contract, and so to ensure that that blood goes through the body and not back into the left ventricle, we have those semilunar valves that are going to snap shut and prevent that backflow. So the semilunar valves prevent backflow into the ventricles. The atrioventricular valves prevent backflow back into the atria. All right, so in terms of heart sounds, so since we all have lots of time these days, and you may be sitting around watching movies, watching Netflix, whatever, maybe your significant other is, I don't know, laying on your chest, listening to the sweet sounds of your heart, and they'll notice that there are two sets of sounds. So there are two beats, or two sounds referred to as lub dub, dum 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 dum. If you ever listen to anybody's heart, that's basically what it sounds like. Well, what are those sounds? Those sounds are those valve closings that we just mentioned. So the first set of valve closings is the AV valves, and then the second set of valve closings there is the semilunar valves. So that's what those sounds are. And if you listen closely, like with a stethoscope, if like you probably all had athletic physicals at some point in your life, and one of the things the doctor will do is sit there and listen to your heart, and you get that during physicals as well. But when they do that, what they're listening for is any sort of abnormality with that sound. So there may be like a sort of a swishing sound, there may be sort of a clicking sound, and based on the sound that they hear, then they might have some ideas about potential defects with any of those valves. If you ever go to grad school for this stuff, you'll probably have to listen to it. We had to be able to identify them in our athletic training program, and they are pretty subtle, so they are fairly difficult to hear. But anyway, so the abnormal sounds with the valve closings will tell you that maybe those things don't fit together quite like they should. Maybe those flaps don't fit together quite like they should, and so one of the ways that we refer to those more colloquially is as a heart murmur. So if somebody has a heart murmur, effectively that is a problem with their valves where maybe the flaps don't fit together quite like they should, or so there's a couple different things there. You can see prolapse is the first thing under heart murmur. So if you've got a prolapse, basically that valve is moving too far into the recessive chamber. Is I guess a way of saying that. So we're talking about the atrioventricular valves. If the, let's say, mitral or bicuspid valve exceeds or pushes more than 2 millimeters back into the atrium, well, that's considered prolapse. So it moves too far backwards. As opposed to regurgitation, in that case, you've got where the valves actually aren't stable enough to entirely prevent backflow. And so in the case of regurgitation, you're starting to get some backflow, some blood is slipping between those flaps back into the atrium in that case. So heart murmurs are something that used to cause disqualification from athletic participation. They used to make people not play sports anymore. I was good friends with a kid back in about middle school. And so when we went to our football physicals to be able to play middle school football, he had a heart murmur and he wasn't allowed to play anymore. So he was never able to play sports. But that thought has changed a little bit. So as of 2015, the American College of Cardiology says that athletes who have mitral valve prolapse, which is one of the more common ones. So mitral valve prolapse, again, the mitral valve's over here. So if athletes have that, they can play as long as they haven't experienced any episodes of fainting or any other sort of symptoms like dizziness with exertion. Those are the big two. And if they have regurgitation, where they actually are losing some blood back into the atrium, they're supposed to go through yearly evaluations and stress testing before they're allowed to continue to play. So now, in many cases, even if you have a heart murmur, you're still able to play, but it depends upon the severity of the condition and which particular condition that we're talking about. And one of the reasons for that, or one of the reasons behind the thought to disqualify people, is effectively if blood is slipping back into the atrium, well, then that reduces the amount of blood that the left ventricle is pumping out. So if the left ventricle is pumping less blood with each beat, it has to increase the number of beats in order to maintain the same output. And so then that can cause essentially too high of a heart rate, which could then potentially lead to an arrhythmia where you lose that normal rhythmic contraction where the ventricles beat from the bottom up, and you get fibrillation, which is just sort of this electrical currents going everywhere and kind of the shaking of the heart muscle rather than that rhythmic contraction. So then that could potentially result in death. And so that was the idea behind disqualifying athletes. And again, that has changed in the last, give or take, 5 years, where that's no longer a primary cause of disqualification from sports. All right, so here's the pathway of blood flow through the heart, and this includes the valves. So you can see that, again, the deoxygenated blood comes back into the right atrium via the superior inferior vena cava and the coronary sinus, goes into the right atrium. Right atrium contracts, blood passes through the tricuspid valve, ends up in the right ventricle. Right ventricle contracts, blood passes through the semilunar valve into the pulmonary trunk, which is one, splits into the pulmonary arteries, so left and right, and then goes to the lungs. And so here is that in graphical form. And this is up in the slideshow that's in Canvas, and also obviously in your book. Then once the blood becomes oxygenated, it comes back via the 4 pulmonary veins, 2 on the right, 2 on the left, into the left atrium. Left atrium contracts, blood passes through the mitral valve, ends up in the left ventricle contracts, passes through the aortic semilunar valve, into the aorta, and then out to the systemic circulation, where the blood then drops off its oxygen, picks up carbon dioxide, and returns back to the right side of the heart. And then you just repeat that process 70 times a minute till you turn over all of your blood volume, and then do that all day, every day. All right, so one of the things that you're probably aware of is that the heart adapts to exercise. So the heart is highly adaptive. And so one of the easiest ways to see that is in the heart rate, or the resting pulse of an endurance-trained athlete. So if we take somebody who is not conditioned, who is basically sedentary, their resting heart rate, their pulse, is going to be somewhere around 70, 72 beats a minute. And if we take somebody who is endurance trained, if they're a pretty decent endurance trained athlete, they'll probably have a resting heart rate in the high 50s. And if you have, let's say, an elite endurance athlete, they may have a resting heart rate in the low 40s. The lowest one that I'm aware of in terms of lowest resting heart rate that I've seen anywhere was supposedly Lance Armstrong's at rest was 38 beats a minute. Now, there are some other factors involved in that, as we talked about. So his blood volume and blood composition, when he achieved that number, is probably a little bit different than most people's. But nonetheless, 38 beats per minute is pretty low. So the question is, why is that an adaptation? Why does somebody who is endurance trained have a lower resting heart rate than somebody who's not? Well, to answer that question, we got to think first about something called cardiac output. And the abbreviation for cardiac output is Q. And so, especially in exercise physiology, so 471, and probably also in 415 or 416, one of those two, you'll see equations that involve Q quite a bit. So Q is cardiac output, and cardiac output is the amount of blood pumped by the heart per minute. So at rest, your Q, your cardiac output, is about 5 liters, and it depends on your total blood volume. What I'm getting at there is that you turn over your entire blood volume approximately once per minute. So if you got 5 liters of blood, you turn over all 5 liters every minute, so your cardiac output at rest is 5 liters. So the components of cardiac output are 2. There are heart rate, so that's your HR, and then stroke volume, which is typically abbreviated SV. So cardiac output then is the product of, you have to multiply, it's the product of heart rate times stroke volume. So one of the things that you see then in an endurance trained athlete, we'll click to the next thing, is that their stroke volume goes up, and because their stroke volume goes up, their heart rate is able to go down. So I'll give you an example, or I'll put some numbers to it to help make that a little bit more concrete. So if you've got the average person average male, who has 5 liters of blood and a resting heart rate of 70 beats per minute, their stroke volume is 71 milliliters. So that means that every time the left ventricle contracts, it ejects 71 milliliters of blood. Well, if we assume that our endurance-trained athlete also has 5 liters, so assuming our endurance-trained athlete has the same 5 liters of blood and they have a resting heart rate of 50 beats per minute, then their stroke volume is 100 milliliters. So they can eject almost 30 mLs per beat more than the untrained person. So that is a much more efficient heart. It gets the same amount of work done, turns over those 5 liters in less beats, so it's more efficient. And again, the primary reason that it's more efficient is that there's a difference in stroke volume. It's able to eject more with each beat, so you need fewer beats. And that trend continues during exercise. So that person who is, and we'll take an untrained college-age male. An average maximal cardiac output for an untrained college-age male is about 22 liters per minute. So they turn over their blood a little more than 4 times per minute, and that gives them a stroke volume of 113 ml. So maximum stroke volume for your untrained average college-age male is about 113 milliliters. If we take an elite endurance athlete, their maximal cardiac output can be as high as 40 liters per minute, so essentially almost double of that untrained person. And what accounts for that is the fact that their stroke volume is 179 milliliters per beat. So 179 mLs per beat in the elite athlete as opposed to 113 means that they can circulate a lot more blood, means that they can deliver a lot more oxygen, and so in being able to do that, they're able to run faster, run longer, because they can produce more energy in the same amount of time, so they can maintain a higher pace. They're going to be a faster runner because they have a more efficient heart. One more thing I wanted to add before I move on to the specific adaptations in endurance exercise is the idea of maximal heart rate. So one of the things I usually ask on this slide is, how do we find what our maximal heart rate is? I mean, the most accurate way to do that is to put somebody on a treadmill with a heart rate monitor and basically just go till they can't go anymore and see what the highest number you can hit is. That's the most accurate way of doing it, but there are ways to estimate it, and usually people are familiar with the idea of the estimation equation of 220 minus your age. So if you are 20 years old, then your maximum heart rate is about 20. That's one way to do it. That is plus or minus 10%. So that gives quite a bit of variability. Some people have naturally higher heart rates, maximal heart rates, and some people have naturally lower maximal heart rates. So, for example, my wife, who's been doing a bunch of endurance training lately, wearing a heart rate monitor, has reached a number pretty close to 200, even though she is 37 years old. So if we were just doing the estimation equation, obviously she wouldn't hit a number anywhere near that high. So there is quite a bit of variability there. There's a more accurate equation, which is called the Tanaka equation, and so that one is 208 minus, and this is in parentheses, 0.7 times your age. So 208 minus 0.7 times your age is a little more accurate than the 220 minus your age. So one of the assumptions in both of those equations is that max heart rate decreases with age. So in the case of the 220 minus age, the assumption is that it drops about a beat per year. And certainly there is a drop-off with max heart rate as it relates to age, but as with anything else, you can slow that decline with exercise. I read a study last year where they looked at elite endurance athletes, so Olympic level athletes, and they traced them from their 20s to their 60s on their max heart rate. And the individuals who continued to train at a fairly high level, so they engaged in strenuous exercise or vigorous exercise at least 5 days a week, those individuals saw a much slower drop off in their max heart rate. Essentially, it dropped half a beat per year. So viewed another way, it dropped 1 beat every 2 years instead of 1 beat every year. So you can slow that decrease or that drop off in your maximal heart rate if you continue to exercise. The other thing I would point out about that is that maximum heart rate is not trainable. So you can't increase your maximum heart rate by engaging in endurance or any other kind of training. That is genetically determined. So the only part of the cardiac output equation that is trainable is stroke volume. So you can't have any adaptations in heart rate. All you can do is basically slow the decline, but you can't add to your max heart rate. All right, so as far as endurance exercise goes, the heart adapts slightly differently to endurance exercise as opposed to strength training. So if you've got an endurance athlete, so here I'm thinking of somebody like a cross-country runner, cyclist, swimmer, rower, anything that is this cyclic contract the muscles, relax the muscles, contract the muscles, relax, that continuous cycle, I'm going to refer to that as endurance exercise for now. So we're not talking 100-meter sprint, we're talking, mile and longer kinds of runners. So one of the things that happens with endurance exercise is you get an increase in venous return. What is that? Venous return is blood coming back to the heart. And so when you've got that cyclic type exercise where the muscle contracts and relax, that then, with every contraction, you're going to push blood back toward the heart. So every time a muscle contracts, think about a muscle in the lower body. When your calf muscle contracts, it pushes down on the veins, and that pushes the blood that was in there up toward the heart, and it'll actually push it past a little valve. And then when the muscle relaxes, that valve prevents backflow. It prevents gravity from doing its thing. And then the next time the muscle contracts, it pushes more blood up through that valve, relax, push more blood up through the valve when it contracts again. And so if you've got lots of repetitive contractions, then you're forcing a lot more blood back to the heart. So the example I mentioned a minute ago is even with your average sedentary college-age male, their maximum cardiac output is going to be 22 liters per minute. So that means that you've got at least 22 liters, or that you do have 22 liters of blood coming back to the heart. And so with that high volume of blood coming back to the heart, what you end up getting then is that you actually stretch the heart out a little bit. So, and the heart muscle responds like skeletal muscle. So it responds similarly in that when it's stretched slightly, it's able to contract more strongly and propel that blood on its way either to the lungs or out to the system. So between the two ventricles, you've probably noticed by now that the left ventricle is quite a bit thicker than the right. So notice how thin the wall of the right side is over here, as opposed to this septum, and then all of the wall of the left side over here is much, much thicker. So the left ventricle, again, the one that's responsible for delivering blood to the systemic circulation, is the most responsive to training. And so with that endurance training, then the effect is that volume overload stretches out particularly the left ventricle, and then it's able to contract more strongly. And so by producing those really strong contractions, the wall of the left ventricle actually gets a little bit thicker, not a lot, but a little bit. And so you get this combination of a left ventricle, it's the whole heart, but particularly the left ventricle, that is more elastic, so it's a little bit stretchier, and able to return to its original position effectively. So it's stretchier and stronger, kind of the two things I want you to get out of that. So it's got that thicker wall, so it's able to eject more blood with each beat. And so those two things then are what lead to that increase in stroke volume with training. Because the left ventricle can both hold more blood, so it can hold, let's say, 200 mLs as opposed to 125, and then because it's stronger, it can eject more blood with each beat. So it can eject out 179 of those 200 mLs if we've got an endurance athlete, and it can only eject 113 of those 125 mLs, probably even a lower number, in our our untrained individual. So endurance training then results in a left ventricle that's stronger and stretchier, and that allows for an increase in stroke volume, which then allows for a decrease in our heart rate. All right, so then our last one on this slide is strength training. So here in terms of strength training, I'm thinking of or describing somebody who is pure strength training. So somebody who's like a power lifter who does, squat, bench, and deadlift, and leg press, and bodybuilding type exercises, and your Olympic weightlifters who do like snatch, clean and jerk, and then variants on those, and lots of squats. So those are your true strength athletes. And so what you get with strength training, so one of the things I want you to think about is like a maximal leg press. So stacking as much weight on the leg press as you can and just doing it one time. Even for the weakest person in the class, that's going to be hundreds of pounds probably, or a similar thing if we did a chest press machine. People are going to be fairly strong with that. The differences in upper and lower body are there are differences in the upper and the lower body, and we won't get into why those are. But you're going to be able to achieve higher pressure numbers with the lower body. Actually, we'll get into that. There's bigger vessels. there's bigger vessels going in the lower body. With that maximal leg press, if somebody were to stack as much weight on there and press it as hard as they can, or press as much weight as they can, those maximal or one rep max types of actions are typically several seconds in length. And so if you're contracting the muscles as hard as you can in the lower body for several seconds at a time, as those muscles are contracting, they're pushing down on all of the blood vessels around them. And so effectively what they're doing on the arterial side, on the side that's delivering blood to those muscles, is that compression actually narrows them and increases resistance to flow. It reduces the diameter of those vessels, but it increases resistance to flow. So because of that, that resistance to flow increases, and so the left ventricle has to pump even harder to overcome that resistance to flow. So this relates to your blood pressure. So if you've ever had your blood pressure taken, and I'm sure everyone has, there are two numbers that you see when you get your blood pressure taken. So normal blood pressure is 120 over 80 in an adult. So those two numbers, the top number is systolic pressure, the bottom number is diastolic pressure. And so systolic pressure, the top number, is a measure of how hard the left ventricle is contracting. Diastolic pressure, the bottom number, is effectively resistance to that flow. And so during a maximal leg press, you're going to get lots of resistance to blood flow because, again, as those muscles are contracting, they're pushing down on those blood vessels and they're narrowing them, which very temporarily increases their resistance to flow. And so then the left ventricle has to pump even harder in order to overcome that flow. And because not only are you compressing on the arteries, but you're also compressing on the veins, venous return goes down a little bit. So you're not getting quite as much blood flow back to the heart. And so the left ventricle is having to contract even harder with every beat, trying to push past that resistance with less blood volume. And so during maximal leg presses, then, the highest number I've seen on one study, the maximum on a particular subject, was their blood pressure was 370 over 360. So the resistance to flow was 360, and again, normal is 80. And so to overcome that really high level of resistance, the heart has to pump even harder. So the systolic pressure, the top number, was 370. So the result there in strength training is what's called a pressure overload, is how that's often referred to. So in the case of the left ventricle in response to strength training, the wall gets thicker because it has to beat really, really hard, has to produce really strong contractions. But because the venous return, it goes down a little bit, you don't get that same overload. So then the left ventricle of the heart doesn't get that increased extensibility. It's not stretchier, but it is thicker and it is stronger. So there are slightly different alterations, slightly different adaptations to the heart in terms of different modes of exercise. All right, so I'll tell you a story about Ryan Shea. So Ryan Shea was an All-American cross-country runner at Notre Dame. And while he was there at Notre Dame, he was a national champion in the 10K. And in addition to that, and I think this includes his post-college career, he was a 5-time national road racing champion. So at the Olympic trials for the 2008 Olympic Games in China, Shea was running in the trial, and at mile about 5.5, he collapsed. And so when people got out there to check on him, they discovered that he had no pulse. He was breathing for a short time, but then soon thereafter stopped breathing. So the question I would have for you is, what might have happened to him? Well, obviously it's something cardiac related. And so the particular condition that Ryan Shea had is something called hypertrophic cardiomyopathy, or HCM is the abbreviation for that. So hypertrophic cardiomyopathy. So as I mentioned, in an endurance athlete, somebody like Ryan Shea, who is a cross-country runner and Olympic level marathon runner, you're going to get enlargement of the heart. But not all enlargement is created equal. And so in somebody who has hypertrophic cardiomyopathy, which is a genetically acquired condition, you get an abnormal growth of the heart. So your typical endurance athlete is going to see, again, a more elastic and extensible left ventricle, as well as a thickening of the wall. But in somebody who has hypertrophic cardiomyopathy, you're just going to get a thickening of the wall without much of an increase in the elasticity. And so the effect then is that, and here's a picture of actual hearts. So you can see on the left side, so this is the heart that has hypertrophic cardiomyopathy, and you can see how thick that interventricular septum is, and then how thick the wall is of the left ventricle over here. And so the result is that you can't have very much blood in this chamber. As opposed to your normal heart here, you can see that there's quite a bit of room inside the left ventricle to hold blood. And so effectively then, the stroke volume goes down because the walls of the chamber are overgrown. So stroke volume has gone down, and so because stroke volume has gone down, in order to compensate for that, heart rate has to go up to keep pumping the same amount of blood. Because remember that cardiac output is heart rate times stroke volume. If stroke volume goes down, heart rate has to go up to offset that. So in addition to the left ventricle's chamber not being able to hold very much blood, you also get a difference in what the myocardium of the left ventricle looks like. So you can see on the right your normal myocardial cells, and so they are, as we'll talk about in a minute, they're short and they're branched to each other, and then you've got the little nuclei here, and you've got their discs where they connect to each other. And so you can see that they're well connected, so it would be easy for them to distribute an electrical signal. In the case of a heart with HCM, you can see that the cells are shaped differently. There's not those nice interconnections there. There's not the branching. And then all of this purple stuff is essentially scar tissue, so it's collagen, right? And so with all of this fibrous tissue in here, one of the things that the heart has to be able to do is to distribute its electrical signal that causes the cells to contract in an orderly fashion, has to be able to distribute that signal effectively. And so if you've got all of this extra scar tissue in here, all this extra collagen in here, then you're going to lose some of that signal. And so you don't then get the orderly contraction or the orderly electrical signal causing the heart to beat effectively from the bottom up. So in somebody who has HCM, that reduced stroke volume is going to cause an increase in heart rate. So you're going to have to get more electrical signals, which then makes it more likely that some of that electrical signaling is going to get lost in all of this scar tissue. And so then what you're going to get is ventricular fibrillation, where you just start to get sort of random electrical pulses. They just kind of go everywhere. And then you get fibrillation, which is where, as mentioned earlier, the ventricles of the heart in particular just kind of shake. You don't get that orderly contraction. You just get sort of a off and on kind of twitchy contractions effectively in the heart. And so then the heart ceases to be an effective pump. You can't circulate blood. And so then that's what leads to the collapse. So as mentioned at the outset of the lecture, sudden death in athletes occurs approximately in 1 out of 100,000 athletes annually in the U.S. About 125 athletes under the age of 35 in organized sports die of sudden death each year, and the vast majority of them are related to cardiac causes, as you would expect. And of those cardiac-related deaths, about a quarter of them are due to this condition, which is hypertrophic cardiomyopathy. Another 20% involve a condition called commotio cordis, which is also known as a cardiac concussion, and we'll talk about that one in a little bit. All right, so in terms of the coronary circulation, how does the heart itself get its blood supply? Let me turn off my arrow there. So as you probably would have guessed from earlier when we talked about the coronary sinus, the heart has its own special blood supply. So the vessels that supply the myocardium, which again is the heart muscle, are the coronary arteries. And so there's a left coronary artery, and you can see the branches off of that. And the left coronary artery generally supplies the left side of the heart. So specifically, it supplies that interventricular septum, so that thing that's between the left and the right ventricles, the anterior ventricular walls, the left atrium, and the posterior wall of the left ventricle. And then the right coronary artery generally supplies the right side of the heart, so it supplies the right atrium and most of the right ventricle. So those two then deliver oxygen to the myocardium, and then the coronary veins, once that blood is deoxygenated, return that deoxygenated blood back into the right atrium, as we talked about earlier. So before we get to that, so effectively what happens, I'm actually going to click back a little bit, and I'll come back to that. So effectively what happens there is that, so you're looking at, again, that frontal view of the heart. So the left ventricle is going to contract. It'll push blood out into the aorta. And then, so again, the aorta is going to stretch and then contract. So it's elastic. And when it contracts, it'll push blood into the systemic circulation. But some of that blood tries to flow back. As mentioned, this aortic semilunar valve is going to prevent backflow back into the left ventricle. But that blood that's trying to flow back into the left ventricle, instead what we do, instead of letting it go into the left ventricle, what we do then is we direct it into those left and right coronary arteries. So, oops, let's get back one. There we go. So you can see that those originate there just past that aortic semilunar valve. So that blood that's trying to flow back into the left ventricle gets redirected into the left and right coronary arteries, and so then that leaves us, or that produces the oxygen supply for the myocardium, for the heart muscle itself. All right, so let's talk about what heart muscles look like. So they are similar in a lot of ways to skeletal muscles, but obviously there are some differences. So one of the primary differences is that they are relatively short. So you can see here, the beginning and end of one particular heart muscle cell, one particular myocardial cell, as opposed to with skeletal muscles. Remember, those run from tendon to tendon, and so those can be really, really long. Those can be a foot long or longer in the case of a long muscle like the sartorius, semimembranosus, etc. So cardiac muscles are much shorter. They typically have one nucleus, although they can have two. Part of the reason they don't need as many nuclei is because they're not as big of a cell. As opposed to skeletal muscle cells are multinucleated, so they oftentimes have many more than one nucleus. Skeletal muscle cells also just run right next to each other, and they don't interconnect with each other. Cardiac muscle cells do interconnect with each other, so you can see this one cell here branches and connects to other cells down here. So you've got some interconnection between them. And I got my pointer back. There we go. So you can see that this cell connects here, but then also branches off and connects down here as well. So they are branched and they are interconnected to each other. So there are a couple things that allow for that, or a couple things that happen at that interface site. So you've got your intercalated discs, and you can see them labeled here. So here's an intercalated disc. And so those are the junctions between one myocardial cell and the next. And in those intercalated discs, you've got gap junctions. And so the gap junctions allow the passage of ions between those myocardial cells. So again, your electrically charged particles, things like calcium, are able to pass from one myocardial cell to another. And then you've got desmosomes, and the desmosomes are going to keep these myocardial cells from pulling apart. So remember that we have desmosomes in areas where there's a lot of either tensile, which means pulling apart, or shear stress, which is pulling side to side. And so in the heart, obviously, there's a lot of tensile stress. Those cells would tend to pull apart, and so those gap junctions prevent them from doing so. In terms of the mitochondria, so remember, those are the powerhouse of the cell. That's where we actually use the oxygen that the cells take up in order to produce ATP aerobically. So your myocardial cells have lots and lots of mitochondria, and in fact, the mitochondria in your cardiac cells may comprise a third of the internal cell volume, or possibly a little bit more than that. So there's lots of mitochondria. So your myocardial cells are solely aerobic. They can't operate anaerobically. Now they can break down things like lactate. So if a skeletal muscle, if you're sprinting, you're going to produce lots of lactate. That drops into the central circulation, ends up in the heart eventually. And so the heart is able to break that lactate down, and so it can use lactate as energy, but the heart itself can't operate anaerobically. One of the other things on there is that the myocytes, the heart muscle cells, contract as a unit. So remember, thinking back to skeletal muscle, we talked about the concept of a motor unit. So inside of your biceps brachii, for example, you're going to have a bunch of different motor units. Some of them are slow twitch fibers, some of them are fast twitch fibers, and so you can contract a few of those muscle cells in the biceps, but not all of them if you don't need to. That's not how it works in the heart. They all contract every time. So one of the reasons for that is because of that, the fact that they're branched, because those ions move from one cell to the next, and so that's what allows the transmission of that electrical charge, of that action potential from one cell directly to the next cell. And so they're going to contract as a unit, as opposed to being able to contract some but not all, like we're able to do with skeletal muscle. How they contract is pretty similar. We won't get into the specifics, but just as an FYI, one of the differences is that you're going to get this influx of calcium into a myocardial cell, and then that's going to trigger the release of calcium from the sarcoplasmic reticulum, and then the rest of it's pretty similar. And so obviously you don't see that uptake of calcium in your skeletal muscle cells, and so that's one of the differences between the two. All right, there we go. Oh, there's your branching. Okay, so the question I have for you related to that is, why is snow shoveling dangerous? And so what I mean by that is, oftentimes in the winter you'll hear about somebody, typically an older person, oftentimes 60 or older, will be out shoveling their sidewalk, shoveling their driveway, and then they have a heart attack. So the question is, why does intense exercise like shoveling the driveway or shoveling your sidewalk, why can that cause a heart attack? And so the answer, try to see if I don't have it on my slide. All right, well, I'll just tell you. So the answer is something called the arteriovenous oxygen difference. Arterio is in arteries, venous oxygen difference. And we're going to talk about this more in the lung chapter as well, so I'll revisit the idea. But the arteriovenous oxygen difference is effectively a measure of how much oxygen tissues take out of the blood that passes them. So at rest, skeletal muscle cells take out about 25% of the oxygen that they see. So then the AVO2 difference is 25%. During really intense exercise, skeletal muscle cells can increase their AVO2 difference up to close to 100%. So you can get a really big difference in a really big change in AVO2 difference in skeletal muscle cells. They can basically, there's two ways to get more oxygen to a skeletal muscle cell. One is that you can increase blood flow, so increase the volume of blood, and then the second is that they can simply extract more oxygen. In the case of cardiac muscle, what you've got is myocardial cells essentially take out almost all of the oxygen that they see all the time. So whereas a skeletal muscle cell at rest is only going to take out 25% of the oxygen that it sees, a myocardial cell is going to take out somewhere in the neighborhood of 80% of the oxygen that it sees. And so in the case of the myocardial cells, then once we start exercising, the only way to get more oxygen to the myocardium is to increase blood flow, because we can't really increase AVO2 difference all that much, so we've got to increase the total amount of blood flow. Well, if we've got somebody who has a plaque buildup in the heart, if they've got atherosclerosis, make sure my arrow's on. It is. All right, so if we've got this plaque buildup in the heart here, then we need to get lots of blood to this distal portion of the left ventricle down here to the apex of the heart. But because of this plaque buildup, we can't get a sufficient volume of blood down there. Because again, so you hear, if you've had relatives that have had heart attacks, or if you're familiar with the concept, they'll talk about that somebody's vessel was 93% occluded. So that means that the vessel was 93% blocked, so it was only 7% open to blood flow. So as you can imagine, then we can't deliver a whole lot of oxygen to these tissues, and then if we engage in intense exercise, so when we start shoveling the sidewalk, we're engaging in intense exercise, and so all of these cells, bring my arrow back, all these cells are going to need lots and lots of oxygen. But because of this blockage, they're not able to get that oxygen, and so they become deprived of that oxygen, and so the result then is that they go into arrhythmia. They just kind of start to shake. They lose their ability to reset their resting membranes, and so they're not able to generate and convey action potentials as they otherwise would be able to, so they just kind of start to shake, and then that sort of, in a way, spreads throughout the rest of the heart, and so then the whole heart goes into fibrillation. Another thing that can bring that on, other than exercise, is that you can get a blockage, so you can get a blood clot, and so then that occludes all blood flow here, even at rest. So when somebody has a heart attack at rest, or when they're not really doing anything, oftentimes those are caused by clots or some sort of other blockage. You filled up that last 7% or whatever open area you had. As opposed to, if that heart attack is brought on by intense exercise, the reason for it is because you couldn't get sufficient blood flow down here past that blockage site, and so those cells die. And again, the primary reason that occurs is because we can't expand the AVO2 difference in the myocardium, and instead the only way to get more oxygen down there is to increase blood flow, but because of this physical blockage, we simply can't. So that's a myocardial infarction or a heart attack. A couple different ways to deal with that, or a couple relatively common ways to deal with that. So you've got a coronary stent, and so this is what a stent looks like. And so what they'll do is they'll take a balloon with a little wire mesh around it, and then they'll inflate the balloon once they're in the middle of that plaque, and that'll compress the plaque, and then you remove the balloon, and so now you've opened the blood vessel back up. But if that's not going to work, something else that can be done is a bypass. And so if you have a relative, like my grandmother, for example, my maternal grandmother has had at least a triple bypass, perhaps more. But let's go with she had at least a triple bypass. What that means then is that you've got at least 3 blood vessels, oftentimes vein grafts, but it doesn't always have to be a vein graft, that go around that blockage. So if our blockage site is right here, we'll have, in this case, an artery graft that comes off of one of the vessels that becomes your carotid artery, comes off of that and goes around that blockage, and so that's going to deliver blood past that blockage site. So bypass is what they do. Think about the blockage site as being kind of like a traffic accident, and so they just get the cars, or get the blood in this case, not to extend that metaphor too far, they get the blood past that blockage site so that everything down here can still get the oxygen that it needs. And so you see a very similar thing here on the right side of the heart. So this person has a double bypass because they have 2 of them. Triple bypass obviously then is 3. All right, so let's talk about the electrical activity of the heart. So the heart, left to its own devices, is able to depolarize spontaneously. So myocardial cells just send action potentials spontaneously. But ideally, we want that spontaneous depolarization to be a little bit more organized. And so what initiates that action potential for the entire organ is the sinoatrial node, or SA node. So the sinoatrial node is in the right atrium, and so on this picture, it's this purple thing right here. So it is kind of in that superior and posterior aspect of the right atrium. And so the sinoatrial node is a special bundle of tissue that has an inherent rate of about 100 times per minute. So left to its own devices, it's going to send 100 action potentials per minute. And so that would then lead to a resting heart rate, or a pulse rate, of 100 beats per minute. But as we discussed earlier, your pulse rate, certainly at rest, is quite a bit lower than that. So the sinoatrial node doesn't operate independently, and so it receives input from both the sympathetic and parasympathetic branches of the autonomic nervous system. So remember that the sympathetic branch is fight or flight, so that's going to speed up heart rate. The parasympathetic branch is rest and digest, and so that's the brakes. That's going to slow heart rate down. So the SA node, while left to its own devices, will depolarize 100 times per minute. It's under the influence of the autonomic nervous system, and so that influence is what actually results in the number of times it really depolarizes per minute. So we're going to assume somewhere in the neighborhood of 70 times per minute. So the SA node is known as the pacemaker of the heart. It originates that electrical signal that then spreads throughout the heart to cause the contraction of the atria and the ventricles. So what you get is the SA node, again, starts that electrical signal. It spreads across both atria, both the right and the left atria, essentially simultaneously. So it's going to cause them to contract. And then as it spreads across the atria, it makes its way down here to this special bundle of tissue called the AV node, so the atrioventricular node. And so what the AV node does is it actually delays the progression of that impulse for about 1/10 of a second. And so the reason that's important is that allows for the atria to contract and keeps the ventricles still at rest, because if we spread that signal too fast, all the heart's going to contract at one time, and so then the heart wouldn't be nearly as effective of a pump. So we have to have the atria contract, delay the signal, and then the ventricles contract. And so the AV node's job is to delay that signal for about 1/10 of a second. Then once we've delayed it, then we spread the signal, or the signal continues along its way along the AV bundle, which is here, and so that's in that interventricular septum through here. So that's the electrical connection there between the atria and the ventricles, is that AV bundle, also known in certain textbooks as the bundle of His, although you're seeing that less often, for the German physiologist who discovered it and named it. So, and then it spreads from there, from the AV bundle to the right and left bundle branches. So there's the left bundle branch there, right bundle branch there, and then into the Purkinje fibers, or Purkinje system is how this book terms it. So that spreads the electrical signal across the ventricles, allows them to contract and wring blood out. And so you can see the spread of the electrical signal here. So we start at the SA node, and then by the time we've hit about 4/100ths of a second, maybe 5/100ths of a second, it has gotten to the AV node, a little delay, and then it continues along its way. So we're down here into the into the Purkinje system down here. or into the bundle branches at the very least, after about 1700ths of a second, and then it spreads all the way out to the most distal aspects of the left ventricle wall or the right ventricle wall in no later than a quarter of a second. So we can send that electrical signal pretty fast. All right, and so then the last thing for this lecture is electrocardiograms. So in other classes, you'll go into a ton of detail on these. All I want you to know for now is what the different waves on the electrocardiogram represent. And so this is a pretty nice picture of what's going on in each phase. So with an electrocardiogram, so you've got essentially three sets of bumps. So you've got the first bump here, which is the P wave, and then you've got what's referred to as the QRS complex, which is the highest of the bumps. And then you have a flat line, and then the next bump or the last bump, which is the T wave. So there's a P wave, a QRS complex, and then a T wave. So what's happening in each of those phases? In the P wave, that is depolarization of the atrias, or atria, threw an S on there. Depolarization of the atria is what's happening in the P wave. QRS complex is depolarization of the ventricles, and then the T wave is a repolarization of the ventricles. So ventricular repolarization is the T wave. And then the other two terms on there, systole and diastole. Remember that we talked about systolic and diastolic blood pressure. Systolic pressure is the number on the top. That's how hard the left ventricle is contracting. Diastolic pressure is the number on the bottom. That's resistance to flow. Systole then is when a chamber is contracting. So usually we're talking about the ventricles, but you can have systole and diastole with the atria as well. So systole is contraction of that chamber. Diastole is resting of that chamber. So systole of the left ventricle is when it's contracting. Diastole is when it's not. It's when it's at rest. All right. So that's enough of this stuff for today. So we'll pick up. I have kind of a combination of chapter 18 and 19, which will be the next one. So we'll finish the cardiovascular system next time. So, and we'll talk about regulation of heart rate, as well as the structure of the arteries and veins. So we'll talk to you next time.